The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. This is your host, Paul Wirkus. It's always interesting for me that every month I get to talk about something with which I might be a little bit familiar or not at all familiar. And from month to month, it's always clear to me that there's a lot that I need to learn to be a more effective pediatrician. And so what we're hoping to do from month to month is to expand our skill set. We're very fortunate this month to have a guest from Children's Hospital Philadelphia, Kristine Fortin, who is the Director of Safe Place Fellowship and Medical Director of the Fostering Health Program at Safe Place Center for Child Protection and Health at Children's Hospital Philadelphia. We're going to talk about care of children in foster care. Welcome to the podcast, Kristine.
Thank you for having me.
We're talking in October 2025. The occasion for this is a great new book that's just come out, a publication from the American Academy of Pediatrics, Fostering Health Standards of Care for Children in Foster Care. This has been a big undertaking, hasn't it?
Yes, it was an undertaking by the Council of Foster Care, Adoption, and Kinship Care, affectionately known as Coffee Cake, one of the councils in the AAP.
And we're just right now past NCE at the end of September. The book launched there, and I understand it's been very well received so far.
Yes, we're very excited, and it's a book that we really hope will serve not just physicians, but our child welfare partners, policymakers, researchers. So we're really excited about the impact that this book can have on the health of youth in foster care.
Wonderful. Well, before we dive in, are there any disclosures that you need to share with us?
No, I don't have any relevant disclosures.
Okay, well, let's jump right in, because the more that I've been looking at this, the more I realize I don't know, and the more I realize that care that I provided in the past, that I can learn more about how to do this better. I wanted to take a couple of points from the executive summary that's on the AP's website about where this book came from. Could you tell us a little bit about what the origin of this committee is?
Sure. So the second edition of Fostering Health came out 20 years ago, and this edition was just published in 2025. The second edition was put together by a task force of providers to really think about standards of care for youth in foster care. Because the AP recognized that youth in foster care do have special health care needs, and they need more pediatric visits, different types of visits, and there's really different care that pediatricians should be aware of. So that was where the initial second edition came from. And over the past 20 years, there's been so much learned. For example, just one example would be trauma-informed care and all the science that we've learned about that. And so it was really important to expand the book. It went from 10 chapters to 42 chapters.
What's the target audience for this book?
The target audience is really everybody who could come into contact with and care for youth in foster care. So for medical providers, there's chapters that are for primary care pediatricians, chapters for pediatricians who really focus on their practice on youth in foster care. And there's also chapters for emergency department physicians and subspecialty physicians, because children in foster care are going to encounter many different providers in the medical system. So it's really for a range. And it's not, like I mentioned, it's not just for medical providers. We also hope that it can be a guide for child welfare professionals so they can understand the healthcare needs of youth, and policymakers and researchers. So it really has a wide audience.
Just a really broad approach to the things that we need to know. And there's a lot to know.
There is 42 chapters worth.
Yeah, let's dive in and see what we can do over the next couple of weeks. Let's talk this week mostly about the medical and mental health needs for children in foster care. What are some of the physical health challenges that kids in foster care face?
Didn't you even think about, as a medical provider, where you're seeing a child within their journey in foster care? And also, it would depend on their age. So the AP has special recommendations for visits for youth in foster care. And one of them is to see youth in foster care within 24 to 72 hours of an initial placement, and then every placement change. So sometimes we'll see youth who are entering a new placement, and because it's happening during a time of crisis, their medical needs just weren't communicated to the new foster parent.
Sure.
So see youth who have like anaphylaxis to peanuts, but they don't have their EpiPen, or they have asthma, but they don't have their asthma medications. So those are some common pediatric problems where we just need to make sure that youth have access to their medications. And then it's also really important to do a full evaluation, like hearing and vision screens, making sure they have access to their glasses, checking their dental care, checking their growth parameters are just some examples.
What's the most effective way to gather that information? A lot of times the kids are too young to share that themselves. How do we get that information?
That's a great question. We do have older youth and teens where we'll ask them their history, and we're really lucky in our clinic to have a nurse care coordinator who's able to help gather medical records, because sometimes youth have had care at different places. So if you have an electronic medical record and you're able to see past medical records, that's a great way to gather. Sometimes we also reach out to schools who might have more vaccine records. And we also reach out to family of origin when we're able, and get history from the parent and ask about where the child's had medical care so we can help to track down that history. You can also work with the case manager from child welfare to see if they have any health information they can share.
And it seems like at the very least, these are kids who may have several problems, and because of lots of challenges that they may have faced, may have been undertreated for some of these things that they know they have.
Sometimes when we do review the records, we'll see that a child was referred for a developmental assessment or a medical specialty appointment and haven't had that chance to complete that appointment. So that is something when we get records, we review and see, what are the medical needs that the child needs at this point in time.
What are some of the behavioral and developmental health concerns that these patients may face?
It's a really important question, and we use some standardized screens in our office. And it's also good to recognize, like you were mentioning, sometimes youth may have missed some of their visits. So for example, usually the MCHAT, if they've missed that visit where they would have been screened and they're still within the age range, it's important to think about doing those screens at that time. So thinking about the developmental level, some of the younger youth have a higher prevalence of developmental delays. And for older youth, we're lucky to have an occupational therapist in our clinic who can help address the academic needs and the academic delays and provide supports.
We always hope that in the current world that we're more abreast of the issues that may challenge these patients. You alluded a minute ago to trauma-informed care. Our approach to children who have issues related to trauma is different than it was a couple of decades ago.
Yes, that's one of the, really exciting developments of being better to understand the impacts of trauma that are the physiologic impacts, and then how now we have more information that we can share with youth and foster parents about how that can manifest clinically in their development and their symptoms, like they might have troubles with sleep or troubles with being hypervigilant, and they need just some more information and trauma-informed specialized care.
And almost by definition, a child who is in foster care would be at relatively high risk of trauma.
Well, just being displaced from the home
Right.
is a trauma.
Yeah.
So the children that we see have experienced trauma. And then there's other, children get placed in foster care because of a crisis. So that's a trauma. And then children could experience trauma within foster care if, for example, they move to a new placement, that placement's disrupted. That's another change and another experience for them.
What are some of the school challenges that we should expect to help patients navigate?
We do see a lot of youth who've had interrupted schooling, and we know that can impact their learning. And when children are experiencing trauma and they're going to school during that time, it might impair their learning if they're really experiencing these trauma symptoms and trouble with attention and really having trouble focusing on the learning because of what they're going through. So we do see a lot of children who need some additional academic supports. And there's a study that shows that a lot of youth, by the time they're 18, have gone to more than 5 different schools during their schooling.
Which is a challenge under the best of circumstances.
Exactly.
And also may have the additional challenge of even gathering the records because it's happening by people who have been outside the household for a good portion of the time.
And sometimes if a school starts initiating like an evaluation for an IEP, but then the child is moved, they kind of had to start over again if the records aren't transferred. So the change in school has a lot of challenges. And also for youth who've experienced a lot of disruptions, like getting to know adults and learn new attachments and then having that disrupted is a challenge.
What are some of the communication barriers and challenges that you might expect to face with a child in foster care?
There's so many more systems involved with the youth in foster care. So there's the child welfare system that you need to communicate information with about their medical needs. And there's different types of foster care placements. So some children are placed with family members who may be very well aware of their medical history and have had a long-standing relationship with the child. But other children may be placed with a non-relative who really has no background information or knowledge of the child's medical history. So that can be a big role. Maybe the pediatrician has been more involved in the child's life and is more of a constant person who can help relay that medical information and be a constant in the child's life.
It does highlight the fact that for my patients who are in foster care and for my patients who may end up going into foster care, it's really important that I be as systematic as possible in putting information together and then gathering the information.
Yes, and really documenting and making sure as children get older that they're aware of their medical history and that they know what they can ask doctors and explaining like this is something, if you have this issue, you can always ask your pediatrician or ask for help. So that is a really important piece of what our medical field can do.
Are there any special populations within foster care that may pose a greater challenge for a provider to deal with?
In our book, we do have some chapters that highlight children with special health care needs within foster care. There's a chapter on children with medical complexity within foster care and the specific challenges for that population. Sometimes it can be really challenging to find a placement with a foster parent who would feel comfortable and who's qualified to handle the medical equipment. There's also a lot of chapters devoted to youth who are adolescents and talking about reproductive health needs. There's a chapter about youth who are transitioning out of foster care, who are the young adults who are also a special population that we need to be aware of how we can support as pediatricians.
Let's talk a little bit about it. We're going to talk about this a couple of times because this is really the foundation of the structure of healthcare. Let's talk again a little bit more systematically about what the FAAP recommendations are for visits for youth in foster care. You talked about the initial health screening visit, and we'll talk about it a little bit more next week because I think it's so foundational. But it seems like that's the opportunity to really put the facts together so that you can take the best care that you can of the patient. You want to talk us through that visit and the subsequent visits?
Sure. And one of the key principles is that children in foster care need to be seen early and often.
And what's
So
the reason for that?
there's multiple reasons. So one is that children do have special health care needs. And as children are spending time in foster care, there's a lot of changes and transition. So it's really important for the pediatrician to keep checking in to see how things are going. Sometimes when a child is first placed, it's a new relationship. And as they get more comfortable in the home, maybe issues will change and develop. So it is really important to have that pediatric support during a child's time in foster care. And you may also find as a pediatrician, like we find sometimes there's multiple issues we want to address. And if we try to do every single thing at one time, it's just too much for the child and for the caregivers. So we try to prioritize, and it could be a good strategy to say, these are really the most important things and have follow-up visits where, we can check in on how those are going and address the other issues as well.
What should go into a comprehensive health assessment? And are there potential barriers in dealing with kids who may be dealing with trauma?
Yes. And I did want to mention just an outline of the visits like you had
Yes,
asked.
please. Yes.
So there's, like I mentioned, initial health screen, which is recommended between 24 to 72 hours when a child is placed in foster care and when they're transitioning to a new placement. Especially the 24 hours, if it's a young infant, that would be really important to make sure, check on their weight, make sure the caregiver has all the information they need for that young infant. After that initial visit, then it's recommended they have a comprehensive health assessment within 30 days. And that's would be a longer visit to really think about all the aspects of health, like the physical health, development, emotional health, mental health, and really take the time to gather all the records and review and do that comprehensive plan for the child. It's then recommended that they have a follow-up of that comprehensive health assessment because, like I said, oftentimes there's a lot of recommendations. So really to, reiterate and see how things are going. And then there's an enhanced schedule for pediatric care. Normally, let's say you have a 5-year-old child, you'd be seeing them once a year. For children in foster care, it's recommended at least every 6 months. And I think if a pediatrician is noticing that there's a lot going on, they could even elect to see the child more often than that.
And as you mentioned before, part of that too is that it's an overwhelming amount of information sometimes, and there may be more information that arises as you go along. How do you deal with issues of potentially of trust and of not wanting to traumatize somebody who may come from a fairly traumatic situation?
Those are really important questions. And it can also depend on the context. So it may be that you're a primary care provider and you're a person who knows this child very well. So
Mhm.
you may be actually someone who the child has the most trust in, when they're placed in a foster care placement that they might not know their caregiver. So that could be something, to just that you're already doing just by
Right.
being, continuity. In the clinic where I see youth, that I'm meeting them for the first time. So some of the things that we do to make the children comfortable is really give them a lot of information up front, introduce ourselves, explain the visit, and let the child know that they do have control over the visit. Like explain the parts that we're going to do. And, when we do the physical exam, we explain these are the steps. We explain exactly why we're doing them. And if there's a part of the exam that the child's really uncomfortable with and it's not urgent, giving that child control to say, okay, is there anything we could do to make this more comfortable? Is there someone in the room, a support person that could be more comfortable? And if it's safe to defer, you could say, maybe if you get to know me and we could do it the next time you come in.
Sure. Yeah, that's great. Let's talk briefly about, because we're going to talk about this in more length next week, issues of advocacy, both individual advocacy and the challenges of advocacy generally, of the big issues that we can help with.
I always think for youth in foster care, I know there's waiting lists for mental health treatment for every child, or there's waiting lists for speech therapy for every child. But when we have patients in foster care, sometimes getting those services can make the difference between keeping a stable placement and having a caregiver that's not able to maintain the child in their home. We had a mom the other day who said, if I got supports and help and someone to give me tips and, like a therapist who could help me, then I really think I could have these children in my home long term. But without any help, that's not something that I could see possible. So when I have a patient and I'm calling provider to say like, hey, can you help this patient? I like to say like they're in foster care. And if we could get them into the service really quickly, that would really help them stay in their placement. And that will make a huge difference in their long-term prognosis. And I find when we advocate like that and communicate, people really understand the value and are really happy to help.
It is a big deal, isn't it? I think one of the cornerstones of primary care is that I do what I can to make this child's issues my issues so that I can help them navigate it. Because while it may be something that's relatively familiar to us, it can be a brand new thing, both for the patients and also for the people who are taking care of them.
Yes, absolutely. And I really do think once people know and understand it, it helps the caregiver to know that, what the issues are and what the plan is. And when you're calling in other providers, they might not be as familiar with taking care of youth in foster care. And when you can give that background, I find people really, like I said, they really are able to help.
How about the issues of transition planning? And I know that can be a difficult subject generally, but what you hope that you can experience over the arc of your relationship with this patient is to be able to again act as an advocate in that process.
Yes. And thinking about if you are a primary care provider, if there's a way that you could see the child a little bit longer, if they're 18 and that's your typical practice that they would transition, if there's a way to continue, that can be something that really is helpful with the stability. And thinking through like from small things to really large things. So we oftentimes will have patients who don't have access to their social security card or getting a state ID. And they said, if you could fill out like a paper, like a health assessment and sign it, that can really help me to get the social security card I need, then I could get a job. So things like that, that you can help patients with and really educating patients about what your role is as a physician and what you could do as a physician and questions they can ask physicians or when they should go, and also educating about their past medical history. Sometimes, like, I've seen patients where I can see their newborn screen was positive for G6PD, but the child wasn't aware. So really make sure to, communicate with the child so they are aware of their medical history.
Yeah, it is a slightly different part of the team then, isn't it? Yeah. Anything else? I recognize we're trying to cover, hundreds of pages with a 20-minute chat, but any other big challenges that you think we should be thinking about in terms of looking for solutions? Next week, we'll talk a little bit more about solutions.
Also really highlighting each child's strengths as well. There is a lot when you read about youth in foster care. A lot of literature highlights that the children, have increased prevalence of health issues and developmental issues, but also really each highlighting and finding the strengths of each child and highlighting the strengths of the relationships that they have with their caregivers. That's something that's really positive and important, I think, in caring for this population. I think it's something that comes out naturally when we're taking care of youth. I think that's why we all went into pediatrics, because we love working with kids and seeing their personalities. And that's why I love working so much with this population, because they're amazing kids, and highlighting those strengths is really important.
Because everyone deserves to know that they have strengths and to see what the strengths are.
Yes. And in our clinic, like I mentioned, we have an occupational therapist who does developmental testing, and we have youth who'll test out gifted. And, that we had a patient who was 10 and was reading at the 10th grade level, and we all were clapping, and it was such a happy experience. Like, highlighting those things are really important.
Absolutely. Hoping to lay the foundation for a great and successful life.
Yes.
Yeah. If somebody wanted to get a copy of the book, Fostering Health, Standards of Care for Children in Foster Care, how would they do that?
Currently, with the AAP publishing website, the book is available there. And after a few months, there also will be an ebook available.
Oh, great. No, that's nice. I mean, it seems like such a valuable resource, and I've only been able to look at a summary so far, but I'm very anxious to be able to spend some time with it. Anything else you want to share with us this week, Dr. Fortin?
One thing that I wanted to share with how the book was made is the Council on Foster Care, Adoption, and Kinship Care really has highlighted the importance of lived experience perspectives. So each chapter was reviewed by an individual who has lived experience in the foster care system. So as an editor, after each chapter was edited, a youth with lived experience, who's now a young adult, would review and give us suggestions and saying, you know what, this wording doesn't sit right with me, or I really think you missed this aspect that you should add, or could you think about adding this resource? So for me, that was really such an important part of the book, and I'm glad I had a chance to mention that.
Is this edition the first time that's been done?
It is.
What a genius idea.
It's really just such an important thing that I've learned from working with Coffee Cake, is really that highlighting that lived experience aspect.
Yeah. Well, that's wonderful. Dr. Kristine Fortin, thank you so much for your time today. I hope you'll be willing to come and chat with us a little bit more next week about how we can then optimize the care.
And thank you to everyone for listening and taking time to learn about this topic.
All right. It's near and dear to your heart.
Yes.
Right. We'll talk to you next week. Thanks for joining us. We look forward to getting together again next time. The Virtual Curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Paul Wirkus, who also composed the theme music. See you next time.